You're listening to Clinical Conversations. The Annals of Family Medicine published an article last week that's sure to relieve the anxiety of men anticipating physical exams. The study concluded that digital rectal examination as a routine procedure in primary care should be dispensed with. We've got the paper's senior author, Dr. Jason Profetto, as our guest. Dr. Profetto serves as the Chair of Clinical Skills and an Assistant Clinical Professor at McMaster University School of Medicine. Welcome to Clinical Conversations, Dr. Profetto.
Thank you very much for having me.
To be clear, this recommendation pertains to routine exams, not to those done on men with symptoms of prostate disease. Is that right?
Yeah, this has actually been a source of a lot of confusion and misinterpretation, and probably the bulk of the criticism I've received so far. So the study looked at whether or not screening asymptomatic men for prostate cancer in primary care or family practice with a digital rectal exam was a helpful and accurate utility or not. So it was to screen asymptomatic men for prostate cancer, specifically using the digital rectal exam.
Okay. How did the research get started? What prompted this?
You know, it's an interesting history because when I started in medical school, it was customary, it was very routine for men, usually over the age of 40 or 50, to come to the family doctor and to have this, quote, rectal exam done on a yearly basis. And it really was some sort of rite of passage that, you know, once a man hit 40 or 50, they were supposed to have it done. When I entered medical school and I found this, I found that it was an interesting question, and it was vague. There wasn't specifics as to why we were doing it. There was a lot of conversation about maybe prostate cancer, but there was never this firm sort of database or literature to support the use of this examination. Then what compounded this was that during medical school, both as a student and then further as a resident and a staff now, the way in which we learn the digital rectal exam is very poor. And you know, there's data, like, you know, for example, in 2012, there was a study done by Nancy and all that actually surveyed students, medical students, to see how often they were doing rectal exams. And at that point, a national survey showed in Canada that 50% of students in clerkship had never actually done a rectal exam. And there's similar studies that have shown similar results. And so if we are not, one, teaching this, and we are not, two, assessing this, and three, we're not getting sufficient practice, then how can we include this clinical skill into a routine cancer screening protocol? And that is what really sparked my interest in this specific question.
Okay. So you did a meta-analysis that altogether included about 9,200 patients who underwent a digital rectal exam. And they also underwent biopsy as a result either of that digital rectal exam, which we'll just call DRE, or a PSA test. But they all underwent digital rectal exam. They all underwent DRE, plus or minus the PSA.
Correct.
Okay.
Yeah.
Right.
So now the big issue there is that in order to see if the DRE was accurate, we needed some sort of gold standard to compare to, and that was going to be, and that mainly revolved around the prostate biopsy. So we had confirmation of pathology that the digital rectal exam was able to predict, and that's how we compared it. And in the end, only 7 studies ended up meeting all the inclusion criteria, which was quite surprising given the fact that we started off with somewhere in the 5,000 mark.
But you wanted to make sure, as I was reading your study, that all of the exams were done by primary care clinicians.
Yeah, that was part of the conversation early on as well. So we got to a point where we saw that a lot of exams were either done by primary care docs or urologists, or in a bunch of studies, it wasn't specified who did the digital rectal exam. So just in order to create a very robust methodology, we wanted to be very specific as to the individual that was doing the digital rectal exam. Then the other thing is that this was a bit more applicable to primary care because this is where a lot of the asymptomatic screening is actually done.
You noted that even among urologists, the agreement on what's a suspicious DRE and what's not are at best fair. The kappa, I guess, is the statistical measure of that agreement among urologists, and the kappa came out to be something like 0.22, which in the statistics textbook that I consulted says, well, it's just fair. And so if it's that unreliable among urologists, who you would guess do these on a regular basis, then it's got to be much less reliable among primary care people. Is that right?
Yeah, and so that's correct. And this is part of the discussion that a lot of people are struggling with. I mean, and when I say a lot of people, I include in that patients, medical trainees, but also doctors, both family doctors and urologists. Most of the urologists I've spoken to have been very supportive and do agree, and we converge on a lot of points. But the thing is, we struggle to define what an abnormal DRE actually is. And I mean, if you actually think about that, so before we step forward and try to talk about the accuracy and the utility of a digital rectal exam, we don't have great confirmation about what an abnormal actually is. And then if you go back to what I was saying somewhat before about the medical school, is that we're not really teaching this. So there's a void right now in the medical education aspect that should be leading up to how we do a digital rectal exam and how we define abnormals, which, so just to make another point, a bit more of a next step, future point, is the next step in all of this, if we want to use a digital rectal exam to screen for prostate cancer in primary care, is we need to go back to the beginning and really have a good conversation about how we should be teaching and assessing this in medical school consistently across the country and continent.
I wanted to ask you what your colleagues have said about the study. What sort of feedback have you been getting?
So the vast majority of my colleagues, both family medicine, both medical students, residents, family medicine doctors, and urologists, have been largely in agreement. We've had very scholarly and academic conversations, and there's a lot of next steps to follow. I would say, though, there's been a good chunk of doctors, and I said patients as well before, but there's been a good chunk of doctors that have strongly disagreed with me. I presented at the Family Medicine Forum last year, this research, and I presented at the Annual Scientific Assembly in Toronto last year, this research as well. When I was at the Annual Scientific Assembly in Toronto, I had rules of engagement when it comes to the digital rectal exam, and one of the rules was we need to leave emotion out of the conversation. For some reason, when we discuss the digital rectal exam, the conversation gets heated, and there's a lot of ad hominem attacks. There's a lot of fallacies committed. At that conference, I had someone tell me that I was scared to do a rectal exam because I was a young physician. And I've had similar criticism. So the conversation does take some bizarre twists to it, and that is largely due to several factors. One of which is the misinterpretation of what this data suggested. I have never said we should abandon the digital rectal exam for all comers. The digital rectal exam can be useful in many situations. But what we did was we studied a specific indication, and we looked back at the education that led to that as well.
So just to be clear, maybe overly clear, you studied this only among people who are asymptomatic and who are just showing up for a regular checkup, say.
Precisely.
They had no symptoms. Okay, all right. So and the compounding all of this is the fact that you identified among those 7 papers whose data you analyzed, you found a very high degree of heterogeneity among the studies, and so you say that the lack of high quality data decreased the reliability of your findings.
Right.
which kind of proves your point that there's no good data, and so raising the question, why are we doing this? So, what's next then in the field? You say, we have to start from the beginning. You have to start all over again and figure out why we're doing this. And in the meantime, what do people do if they want to do screening?
Yeah, so excellent questions. Now, the first question, what should we be doing, or what is the next step? So firstly, I'm all for screening. I think if we can catch something early, prevent it from becoming something bad, I think that makes a lot of sense. But, an ounce of prevention is worth a pound of cure. I agree with all of that, and I ascribe to that philosophy. The challenge is, though, is that when we come up with a screening protocol or a screening program, it really needs to be based on reliable, robust scientific data. One of the major risks with screening is the risk of a false positive. Many people will dismiss this as being trivial when in fact it's not. And I've seen false positives cause tremendous amount of psychological, physical stress, but also, I've seen situations where it's actually been traumatic to have a false positive. So we need to weigh all the pros and cons for any screening protocol or program that we're looking at developing. So specifically for prostate cancer, we need to look at the things that we can use at present that may be helpful in a screening program, whether that's the digital rectal exam in conjunction with something else, whether or not that's the prostate-specific antigen or the PSA. There's even some literature like looking at the utility of MRIs, and there's other things coming down the line. So we need to look at things that can help detect prostate cancer very early before it becomes a problem. So we have to have that conversation, and we need to research that. If the conversation goes to the point that we still want the digital rectal exam, then we need to back up, look at the medical curriculum, and really come up with a better way to teach and assess it. The other thing in all of this is that this study showed that there was no evidence to help support the use of the DRE. We didn't actually have evidence that it was not supportive or not accurate. We have a lack of supporting data, which is a little bit different than evidence against, as opposed to the absence of evidence for.
Yeah.
So I think we really need to consider those things in moving forward to look at prostate cancer screening. Now, the last question that you asked me is also a very important one. In the meantime, what do we do? The truth is, the only thing for men in terms of cancer screening in asymptomatic people that really works is colorectal cancer screening with either fecal occult blood, the flexisigmoidoscopy, or colonoscopy. Other than that, we don't have good screening protocols for any of this or for any of the cancers that exist for men. So the prostate cancer, the truth is there's probably not much we can do at present, which is similar to osteosarcomas, which is similar to melanomas, which is similar to different types of lung cancer. It falls in a group of things that we would like to screen for, but perhaps can't at the moment.
Okay. And I was going to ask you, what would you like to see happen as a result of your research, but you've answered that pretty clearly. You've made a recommendation, and so I wonder what's happening at the McMaster clinics as a result of that recommendation. Have they changed guidance, or is it still under discussion there?
Yeah, I think a lot of it is still under discussion. Our research was very focused on a specific question related to the digital rectal exam. The Canadian Task Force for Preventive Healthcare Screening recommends against the use of the digital rectal exam or the PSA in low-risk asymptomatic men for prostate cancer screening just in general. So current national guidelines conflict, but the Canadian Task Force, in choosing wisely, recommend against the screening of prostate cancer at present. And often what I tell my patients is that we're currently looking at different ways of improving our screening protocols.
All right. Well, I want to thank you, Dr. Profetto, for spending time with us today.
Thank you very much, and it was a pleasure.
That was our 219th edition. All earlier conversations may be found at podcasts.jwatch.org. We come to you from NEJM Journal Watch. Kristen Kelly is the executive producer here for the NEJM group. I'm Joe Elia. Thank you for listening.